So there's a lot of influencers who really overstate the benefits of hormone therapy, right? Like it's not really going to cause significant weight loss or prevent weight gain. It's not totally clear that it helps with mood symptoms or even sleep is a little more ambiguous. But the one thing it really works for is hot flashes. So that would be my thought is like,
start there.
Start there.
'Cause it's hard to be a person with a body these days when bonkers TikTok diets are all the rage. And why are the seats so damn small on the airplane? 'Cause it's hard to be a person with a body these days.
You are listening to Burnt Toast. I'm Virginia Soul-Smith. Today we are back with part 2 of our excellent conversation with Dr. Mara Gordon, where we are answering all your questions about weight and health in perimenopause and menopause. If you missed the first half of this conversation, definitely check out episode 203. That's where we get into why weight gain is so common in menopause, how much protein you really need to eat, and so much more. I'm also going to give a shout out to episode 167, which was Dr. Mara's first appearance on Burnt Toast. In that conversation, we dive deep into her approach as a size-inclusive, weight-neutral doctor, which means, as she says, not yelling at her patients about losing weight. If that sounds radical and you're new to the idea that a doctor can treat really any of your health concerns without pushing weight loss on you, this is a must listen. Today, we're diving right into when you should consider hormone therapy, what to do about high cholesterol and menopause, and Dr. Mara's top 3 tips for what you can do right now to feel better during this amazing but very chaotic life stage. So here's Dr. Mara. I want to do Laurie's question about hormone replacement therapy, since that is still one of those topics that people are like, is it good, is it bad? I don't know. So Laurie asked, is there a reason why a doctor would not want to prescribe hormone replacement therapy? My doctor seems more willing to treat individual symptoms instead of using HRT. Is that maybe because I'm still getting my period?
I love this question. Now we can nerd out about the interpretation of scientific research. So first I'll just briefly say, Laurie, no big deal that you said HRT, just so everyone's aware, the preferred term is menopausal hormone therapy or just hormone therapy.
Okay.
And it's not a huge deal, but I think the North American Menopause Society uses menopausal hormone therapy. And I think the idea is that like hormones don't necessarily need to be replaced. It comes back to that idea of like that menopause is a natural part of life. And so the idea that they would need to be replaced is not like totally accurate terminology. But a lot
we're
of
not
people
trying to
use
get
that
you
term.
out of menopause. By
right.
like pushing you back into some pre-menopausal hormonal state. Okay, I like that.
But again, not a big deal. You'll see that term used, and a lot of doctors still use that term. So I graduated from medical school in 2015. And I remember one of the first times that a patient asked me about using menopausal hormone therapy, and I was terrified. And I was still in training, so luckily I had a mentor who guided me through it. But I had absorbed a very clear message from medical school, which is that menopausal hormone therapy will cause heart disease, cause pulmonary emboli, which are blood clots in the lungs, and cause breast cancer. And I was like, I'm going to cause harm to my patients. This is scary. And I had also learned that hot flashes, they weren't life-threatening. So a patient could just use a fan and she'd be fine, right? She didn't need medicine for it.
Cool.
And I think there's a lot of things. I mean, I think the sort of dismissal of the symptoms is just straight up misogyny, right? That like, oh, you should just live with these. You're tough, you're a woman, you can do it. This is just the next stage of it is just misogyny, right? But the fear of using menopausal hormone therapy has a sort of specific historical context, which I'll do my best to sort of briefly summarize. So there was a major study called the Women's Health Initiative, and it was a randomized control trial, which is like the gold standard in medical research, where people were given estrogen and progestin to treat menopausal symptoms, or they were given a placebo. And it was actually halted early because they found that there was an increased risk of breast cancer. And this was on the front page of the New York Times. It was a really, really big deal. I think it was on the front page of the New York Times in 2002 or 2003. I was still in high school at the time, but 15 years later, I was starting out as a doctor and I was still absorbing its message. And I think a lot of doctors who are still in practice have just deeply absorbed this message. But there's a lot to consider here. The first issue in the way that information about the Women's Health Initiative was communicated is the difference and nerd out with me for a second here, the difference between absolute risk and relative risk. And this is a really subtle issue that's often communicated really poorly in the media. So I looked it up in the initial paper that came out of the Women's Health Initiative. There was a relative risk of 26% of invasive breast cancer, right? So that meant that the people who got the estrogen and progestin, as opposed to placebo, had a relative increased risk of 26% compared to the placebo arm.
Which sounds high. Sounds scary.
Sounds terrifying, right? But the absolute risk, meaning, so that's risk in comparison to one another, but the absolute risk, meaning like if you're a patient taking the estrogen and progestin, your absolute risk was 8 people out of 10,000 women a year. Right. So it's very, very small. Yeah. And this is an issue I see in medical journalism all the time, that we talk about relative risk, like your risk compared to another group, but the absolute risk remains extremely low. And just to round it out with, I looked all this up, the absolute excess risk of cardiovascular events, right? So that's like a heart attack, a stroke. So the absolute risk was 19. So 19 cases of a cardiovascular event out of 10,000 women a year. Right.
Wow.
So people freaked out about this. And the way that it was covered in the media and the fact that they halted the study early was like.
And I was doing women's health journalism at the time, so I fully own having been part of that problem. Like, we definitely reported on the relative risk, not the absolute risk. I look back and I'm like, what were we all doing? We ended up taking this medication away from millions of women who could really benefit from it.
I found a paper that showed between 2002 and 2009, prescriptions for menopausal hormone therapy declined by 60%
I'm
in the
not
United
surprised.
States. So in the aughts, right, and then even up until the time I started my training, right, in 2015, we're just seeing a huge decline in hormone therapy prescriptions. One other thing that's also super important to acknowledge about the Women's Health Initiative is that they enrolled women over 60, which is not really representative of women who want or need hormone therapy, right? So the average age of menopause is 51, and the vast majority of women who are experiencing symptoms that would respond well to hormone therapy, which is mostly hot flashes, right? Which we call vasomotor symptoms of menopause, but it's basically hot flashes. They're much younger, right? So they're sort of approaching menopause, late 40s, right after the menopausal transition, early 50s. And then they don't necessarily need it anymore after their symptoms have improved.
And wouldn't it also be true that women in their 60s, you're going to see more incidence of cancer and heart disease in that age group than in women in their 40s anyway?
Yeah. And so there have been all these subsequent analyses, which is why now we're seeing menopausal hormone therapy on the upswing, right? That there's a lot of increased interest in it. The American College of Obstetricians and Gynecologists recommends it. The North American Menopause Society, the British Menopause Society, like basically it's not that everybody needs it, and we'll get to that in a second, but that it is a totally safe and appropriate treatment for specifically, and most importantly, for vasomotor symptoms of menopause, right? So for hot flashes. So there's been all these further analyses of the Women's Health Initiative data, and then from other studies too. And basically it shows that when the hormone therapy is initiated before age 60 or within 10 years of menopause, there's actually a reduced risk of heart disease and reduced all-cause mortality. So the timing matters.
Okay.
Right? Isn't that so interesting? The timing matters.
Super interesting.
Yeah. Also, the route of administration matters. So what that means in English is that an estrogen patch, or what we call a transdermal estrogen, right? So trans meaning across and dermal meaning the skin, seems to have a lower risk of blood clots. So one of those fears of the initial Women's Health Initiative data was that you might have an increased risk of blood clots, but something about the way that the estrogen is metabolized, it's not metabolized through the liver when it's absorbed through the skin. And something about that process seems to decrease the risk of blood clots. So that's why your doctor, if you're interested in menopausal hormone therapy, might recommend an estrogen patch rather than a pill.
Got it. Cool.
I just want to be very clear about this, that starting menopausal hormone therapy, it's not clear that taking hormones prevents heart disease.
Right.
And that's one of the big claims I see with menopause influencers, that like everybody should be on this, every single person needs it. That is just not, the data don't support it at this point in time. And the major menopause organizations do not recommend it as a universal, just preventative treatment for everybody. But now it seems like the pendulum's sort of swinging in the opposite direction, right? That I learned like, be afraid of menopausal hormone treatment. and menopausal hormone therapy. And now there's all these menopause influencers are saying everyone should be on hormone therapy. I don't know the answer. And so the way that I try to parse through all of this noise is, go to trusted sources, right? So I stick to society guidelines like the North American Menopause Society, the British Menopause Society. They're run by world experts in menopause, and they publish a lot of patient-facing information. So that's a good place for people to look if they want rigorous, evidence-based information.
All right. So we don't need to be terrified of hormone therapy. And you can be on it if you're still getting your period, right? Just to finish Laurie's question.
Oh, yes. Well, so, if you're still getting a period regularly, so if you're sort of more in perimenopause than past the menopausal transition, we'll often use contraception to help. And you can have a lot of the same benefits from using contraception in that stage. Also, just because unintended pregnancy still can be a thing in your 40s. But yes, you can absolutely use what we think of as menopausal hormone therapy while you're still getting a period too. But it is important to be aware that that is not effective for pregnancy prevention.
Right. Since we talked a little bit about hot flashes, I'm going to jump to Judy's question so we can kind of round that piece out. Judy says, one of the things I am really struggling with is the way I have lost all ability to regulate temperature. I am boiling hot almost all the time, and the slightest thing makes me break out into a full sweat, which makes me not want to move at all. My doctor has not been super helpful in navigating this. What can I do to mitigate this issue, if anything? It is so very hard for me not to blame the size of my body for this, since the correlation seems so clear. Smaller body, less sweating, larger body, sweating all the dang time.
Judy, I empathize, first of all. And I guess before I dive into that, maybe just one caveat. I can't really give medical advice to Judy. I think there's a lot of things that could be going on, and it's really important that you see a doctor and sort of get a full history and physical exam, and et cetera. So caveat there. I will say that this is one of the things that menopausal hormone therapy is extremely helpful for is hot flashes.
That was my first thought was Judy's doctor should be exploring that option for sure.
Totally. So there's a lot of influencers who really overstate the benefits of hormone therapy, right? Like it's not really going to cause significant weight loss or prevent weight gain. It's not totally clear that it helps with mood symptoms or even sleep is a little more ambiguous. But the one thing it really works for is hot flashes. So that would be my thought is like,
start there.
Start there.
Yeah. And on the feeling like you want to blame your body for it, Corinne and I joke about this. Like, I don't know if Judy identifies as fat, but as someone who identifies as fat, like, yeah, I often feel like I'm sweatier now than I was when I was thinner. I run warmer. All my skinny friends will be like bundled up in coats and I still won't be wearing one in like October. I do notice that. And I think that this is a situation where even if that is a fact that you're larger and you're sweatier now, which it is a correlation. We don't know that that's the causation. It's like, is that worth putting yourself through the hell of weight loss in order to see if that helped? You may decide, yes, it is, if hormone therapy doesn't work for you. But that's one of those times where I bring it back to like, okay, what would actually make my daily life miserable? And like, I can drink water. I can be in AC. My friend has this nighttime cooling bed thing that she really loves.
I've heard of those. Yeah.
I'm going to drop a link to that in the transcript. So I think there are options to mitigate your suffering with this. Medicine is definitely an option before you go to the like, okay, my body size has to be the thing that changes.
I totally agree. Right. And yeah, I think a lot of people this is sort of zooming out to think about the way that we pathologize weight loss in so many ways and so many sort of sectors of our culture, right? But I just deal with this all the time where people, tell me in my clinic that they want to lose weight. And when I sort of gently ask, like, what are you hoping to achieve? What are your goals? They're often things that can be achieved through other means. Like people say, my clothes don't fit, right? And, most of my patients are low income, right? I'm not trying to be flippant about the idea that everyone can just go and purchase a new, multi-$1,000 wardrobe at the drop of a hat, right? But like, it is possible to get new clothes in affordable ways, right? Like, don't torture yourself with clothes that don't fit because you feel like weight gain is a moral failing, right? And I think that there are things that we can do to help keep us at a comfortable temperature, right? Wear clothes that feel good air conditioning is an amazing modern invention, and, cool beverages, whatever. Total ice cream, excellent.
Popsicle clock's very important in my summer right now. Very important.
Totally.
Yeah.
Wait, what's a popsicle clock?
Oh, popsicle clock. It's just the time of day where you eat popsicles. It could be 9 a.m. It could be 4 p.m. Just whenever I feel like we need to add popsicles to a situation.
I love it.
Cheers up children and adults, I find.
I think we all need more popsicles in our life. Yeah. That is absolutely for sure. Anyway, yeah. So I think what I'm hearing from Judy's question is like, again, shame about body size, and also sort of this, I think, which I blame doctors for in many ways, this like myopic zooming in on weight loss is like the only possible solution. And, some people do benefit from weight loss, right? I'm not opposed to the idea that anybody would ever want to lose weight. I don't think that's like a betrayal of fat solidarity necessarily, but that there are other things you can do just to make your life feel better in the meantime. Or not even in the meantime, even if you choose to never pursue weight loss, right? Like there are things you can do to feel better, and we shouldn't deprive ourselves of those things.
And you don't know that it's the weight gain. It could be age and hormones. Like there's lots of thin women getting hot flashes all the time. So it wouldn't necessarily solve the issue. And I think that's important to keep in mind as well. Okay, this question is from Michaela. I am super curious about the connection between perimenopause, menopause, and mental health symptoms, specifically an uptick in anxiety and depression. Is this a thing? We also got some questions about whether perimenopause and menopause exacerbate ADHD symptoms. I don't know that we have time to get like super detailed about each of these, but if you want to talk generally about what do we know about the correlation between this life stage and mental health.
Yeah, so this is a question I get a lot from my patients, and I've just seen a lot of discourse about online. And the short answer is there is probably some kind of connection between the hormonal changes of perimenopause and the menopausal transition and mental health. Do we understand it? No. So, I mean, ADHD specifically, I will say, is really not my area of expertise. It's a very complex mental health condition, and I have many patients who have a diagnosis of ADHD. I'm typically not the one who diagnoses them. That being said, estrogen affects neurotransmitters. Neurotransmitters are implicated in ADHD. Declining estrogen does seem to affect dopamine in particular, which is implicated in ADHD. And anecdotally, I've had many of my patients say that they feel like their symptoms of ability to focus and sustain attention, and also that they experience brain fog as they enter perimenopause and menopause. I've definitely seen many patients concerned about this and coming to me for advice. So there's probably something going on, and a lot of researchers are really actively studying it, but we don't know yet.
Do we know if this is something that hormone therapy can help with?
So I think the answer is, I don't know.
Yeah. What about anxiety and depression?
I don't think the data are there, right? So these large-scale studies that look at menopausal hormone therapy is usually not considered a treatment for like mental health conditions that are often frequently associated with the menopausal transition. We have great medicines for those conditions, right? Like we have good treatments for ADHD. We have good treatments for anxiety and depression. And sometimes during the menopausal transition, patients might need an increase of those treatments, right? So going back into therapy, if you've been out of therapy, increasing your medications or restarting a med that you may have stopped years ago, those are all totally valid approaches during this phase. And because the science is so sort of inconclusive at this point, what I'd say is it's okay to trust your body, right? And if you notice changes in your mental health associated with perimenopause or menopause itself, like ask about it. Don't be afraid to advocate for yourself. And while hormone therapy, it doesn't look like it is an effective treatment specifically for those symptoms, there are other treatments and you should feel empowered to ask about them.
Awesome. The next question is going back to some of the diet and exercise stuff. This person writes, since recently reaching menopause, my cholesterol has become high. I understand there is a proven link between menopause and increased cholesterol and that weight is part of the picture. I'm trying to lower my cholesterol with focus on nutrition and exercise, but it is fucking with my head because it feels like a very restrictive diet. I'd love any thoughts on the menopause cholesterol connection and keeping cholesterol low with nutrition and exercise without falling into the abyss of obsessing about how many almonds I've eaten.
Oh, that is such a good question.
Yeah, the almond thing. Oof, rough.
Yeah. And almonds are really good in some scenarios, but also just like kind of a sad snack.
Yeah.
I always think about President Obama eating those like 8 almonds or whatever.
Turned
You
out
know
that
what
was
I'm
a
talking about?
joke. He wasn't really
Was it?
doing it.
Oh my God.
But just the fact that he could say it and everyone was like, yeah, seems like something he'd do.
That is hilarious. And and it just shows how with information online, like the initial story sticks, right? Like to this day, 10 years later, I still thought that Barack Obama ate almonds as his like indulgent midnight snack every single night. I hope the man is eating some ice cream and living his best life. Okay, so there is absolutely a link between menopause and elevated risk of cardiovascular disease. Within the term cholesterol, there's different types of cholesterol, right? So I wouldn't really say to a patient like your cholesterol is high. We might say like your LDL cholesterol is high, which is, again, sort of moral language, but has been known popularly as like the bad cholesterol, LDL cholesterol. And LDL cholesterol is a proxy for risk of cardiovascular disease. I will say it's not a great one. It's kind of a blunt instrument. And we measure it and we treat it because we don't have other great ways of predicting cardiovascular risk. It is not the sort of full portrait, but it's certainly a risk factor for developing cardiovascular disease. And the transition to menopause seems to impact LDL cholesterol, other biomarkers of cardiovascular disease, and just increases your risk for cardiovascular disease. And what's interesting, I think we talked about this a little bit already, is that this risk happens independent of normal aging. So, for example, women who go through menopause early start developing this increased risk earlier than women who go through menopause slightly later. And overall, we see that women develop cardiovascular disease at rates lower than men and later in life than men. And there's a hypothesis that this has to do with menopause, right? That there's a protective effect of estrogen. But then when your estrogen starts to decline in menopause, it puts women at an increased risk compared to where they were pre-menopause. And interestingly, there's also some data to suggest that the severity of menopause symptoms, particularly vasomotor symptoms like hot flashes or sleep disturbances, may indicate risk for developing cardiovascular disease. So this is not to scare everyone, but it's good to have knowledge, right? That if you're having really severe hot flashes, it may indicate that you are at slightly higher risk for developing cardiovascular disease than somebody who is not.
Interesting.
Yeah. So all of this is to say that when I talk to my patients, the intention of having this knowledge is not to make you feel shame, but is to have knowledge to help mitigate risk factors in ways that feel aligned with your values and ways that feel aligned with the way that you want to pursue health in your life, right? And so I would approach this reader's or this listener's question with my same approach to all of my patients' questions about, I have hypertension. Does that mean I need to lose weight? I have diabetes. Does that mean I need to lose weight? And the answer is that we have many treatments that can help you address these concerns independent of weight loss, which is not to say that you cannot pursue weight loss too, right? And if using a GLP-1 agonist to try to reduce your visceral adiposity is aligned with your values and you can tolerate the side effects and you feel good about it, and it's covered by your insurance, that's totally a reasonable approach, but it's not the only one. That makes sense? Yeah.
Yeah, definitely.
So I think what I'm hearing from this patient is the menopause flavor of like what I do every single day in my work as a size-inclusive doctor, which is like, how can we disentangle weight stigma and body shame from these questions of how to lead a healthy life? And the idea of giving you more information, I hope, is not to shame you or make you feel guilt for the relationship between body size and risk of cardiovascular disease, but instead to give you information that might help you take proactive care of your body, right? And proactive care might mean, committing to an exercise routine. Proactive care might mean taking a statin. A statin's a very common cholesterol medicine, like Lipitor. It might mean getting your blood pressure under control and taking an antihypertensive. So, there's a lot of ways to treat these issues, and there's no one-size-fits-all approach.
I also want to say on cholesterol specifically, I did a piece that I'll link to digging into the connection between nutrition and cholesterol. And the data is not as strong as I think a lot of doctors are telling folks. The impact of diet on cholesterol is not as clear-cut as we think. the benefit of making dietary changes, the amount it could lower cholesterol was not huge. It was like 3 points or 6 points or something in one of the studies we looked at. And so if it's making you crazy to count almonds, it's possible that like considering a medication might be a more health promoting strategy for you because it will be less stressful and it will have a bigger benefit on your cholesterol than just trying to control it through diet and exercise.
Yeah, I totally agree. I think there's a really strong genetic component that we haven't fully understood.
Yeah.
And medication is a totally reasonable approach and very safe approach, honestly. Statins are pretty benign medications. They're pretty inexpensive, pretty minimal side effects, which is not to say nobody's paying me from the statin companies, I swear to God, but they're pretty benign as medications go. And I think it's a totally reasonable way to approach this issue.
I just think it's one of those times where this is the shame coming in, where it's like, you should be able to fix this with how you eat and exercise. And so you don't get the medication unless you fail at that. This is a framing that I've encountered from doctors. And it's like, what if we gave the medication? What if we also consider diet and exercise, but don't make that a pass-fail situation in order to earn the medication? There's like a weird thing where doctors sometimes hesitate to give the medication that might really have the benefit because there's like this, you have to do it the old-fashioned way mentality first.
And even the language you're using, Virginia, is like we use in the medical record. And I've tried to stop it, but that's like the way we're taught to describe patients is we'll say like patient failed XYZ treatment,
Like,
right?
what?
Yeah. And it's very confusing, especially now that we're in an era where everybody has access to the medical records, which is good. They're reading that and they're like, what does that mean, right? I feel like we're both at once overly invested in pharmaceutical treatments, right? And underinvested, right? We kind of like moralize it both pro and con sometimes. Like we moralize it like, you know, if your BMI is 26 or above, you need to be on a GLP-1 agonist, which is just false, right? There's a lot of discourse about GLP-1 agonists and weight loss, just like everybody needs to be taking these, which is just not true.
Right.
And is so problematic in the way that we think about autonomy and how people get to, you know, define their own definitions of what it means to be healthy, right? But on the other hand, I think we often underutilize medications because there's this sense, like you're getting at, that we kind of have to exhaust all of your willpower options first.
Right.
And it's somehow failing to use a med. And that is really false too. Like they're really useful tools.
Right.
Science is really useful and we shouldn't feel ashamed to use it.
All right. And our last question I like, because it just will give us a chance to kind of sum up some key points, I think. This person writes, as a postmenopausal woman, I feel like I'm swimming in information and I'm overwhelmed by it all. What are Dr. Gordon's top 3 pieces of advice out of all of the hoo-ha? Meaning, if women at this time only did these 3 things, it would make the biggest difference. And then they just added, you know, it doesn't need to be different for perimenopause versus postmenopause, or maybe not. So what are your top 3 tips for surviving this life stage?
Oh my God. If only I knew. I'm flattered that you're asking, and I will do my best to answer it, but I don't think there's a right answer at all. So I've thought about a couple things. I will say that, you know, longevity and wellness and health span is extremely complicated, but it's also kind of simple, right? So sometimes the advice that we've just heard over and over again is actually really, really good, right? So sleep. Are we sleeping enough? Staying engaged with social relationships. That seems to be extremely important for longevity. And it's kind of amazing, actually. Like, you know, when they do these like long-term studies on people who are thriving into old age, like they have really strong relationships. And that is so important. Moving our bodies, right? And it does not need to be punishing workouts. Gardening. I know, Virginia, I love receiving your gardening content online. Gardening is an amazing form of exercise and can be very life-affirming and does not need to feel like punishment. But just sort of getting up, moving our bodies, sleeping enough, maintaining relationships, cultivating a sense of purpose and meaning in our lives. It's actually been really studied, right? That people who have a sense of meaning and have a sense of purpose in their lives tend to live longer and live longer, healthier lives. So all of this is to say that like it's complicated, but sometimes it's not. And there's a million people on the internet who want to sell you a miracle drug, a miracle supplement, a miracle weighted vest, whatever. But sometimes simple's good. Easier said than done, right?
Yeah.
Yeah, but yeah.
But start simple.
Well, can I ask, what do you think would be a piece of advice, Virginia, that you might give to that?
I think that's really helpful for us to keep in mind. The things that might protect our health the most are also, I don't know, I find sleep, social relationships, and movement all very joyful as well. And so the idea that like doing things that makes you happy and reduces your stress can be health promoting is great. And I think that's something, especially in midlife, we are all incredibly busy. We're holding a lot of things together. A lot of us are caregivers, maybe sandwich generation caregivers, like prioritizing your own joy in that feels really wonderful. All right, so speaking of joy, let's do some better. Dr. Mara, what do you have for us?
I have a Philadelphia-specific one, but hopefully it can be extrapolated to your listeners in different locations.
Love
it. I have recently been really craving soft serve ice cream. And so I Googled best soft serve in Philadelphia, and I found this Vietnamese coffee shop called Cafe Roasters, which is in North Philly in a neighborhood called Kensington, has condensed milk soft serve.
Wow.
So good. And so I had to give a lecture at a medical school in the north part of the city early in the morning. It was like at 8 a.m. And I was like, oh, I'm never up in this neighborhood. I got to get over there. And I went after I gave my lecture and I bought myself ice cream at literally 10:30 in the morning. And I ate it in my car and it was so good. But condensed milk, so good. But soft serve in general is my butter. But for those of you in Philly, go to Cafe Roasters in Kensington and get the condensed milk. It is chef's kiss. Delicious.
I'm going to kind of double up your butter with mine and say ice cream in general is my butter right now. And then, so something that comes up a lot for me as a parent is figuring out how to have one-on-one time with my kids, because since we have joint custody, they kind of move as a package, so I get kid-free time, which is wonderful. But then when they're with me, it's just me. So one thing I've been figuring out is like pockets of time when I can take one kid out for ice cream. And it's usually like a sibling is at another activity, and so we have an hour to kill. And often we would just like wait for the activity or go home and come back, and then you're just driving. And now I'm like, no, that will be our ice cream break. And
I love that.
So one kid's at the library doing her book trivia team stuff, and the other kid and I are getting ice cream while we wait for her. And it's great one-on-one time with kids. Obviously, the ice cream is delicious. And the other thing I've realized, especially if you have younger kids who are still building restaurant skills, like ice cream is a great practice run at being a person in a restaurant, which is really hard for kids, understandably.
It is.
And it's like the one food thing that they're like excited to go do. Like you do have to sit and practice eating it somewhat neatly. Like there's a high mess potential. My pro move for that is always have wipes in your car.
Obviously.
Bring the pack of wipes in. Even now, my kids are almost 12 and 8, and I'm like still bringing the wipes in when we get ice cream. But yeah, it's like great practice for them, and it's good one-on-one time. So yeah, ice cream dates.
I love that.
It's good.
And it's so intentional, like about sort of creating traditions with kids that feels really special.
Yeah.
But I will say I had my ice cream solo, and that was
also
really good solo ice cream too.
Well, thank you so much for doing this. This was really wonderful. Just quickly tell folks where they can find you and how we can support your work.
Yeah, thank you so much, Virginia. I'm such a fan of your work. It has been so meaningful to me, both personally and professionally. So it's such an honor to be here again. So you can find me on Substack. I write the Substack called Your Doctor Friend. It's at maragordonmd.substack.com. And I'm on Instagram at maragordonmd too. And you can find a lot of my writing on NPR as well. NPR's health blog called Shots. And I'm writing a book.
Yay!
It is called tentatively How to Take Up Space. And it's about body shame and healthcare and the pursuit of health and wellness. So lots of issues like we touched on today. Hopefully that will be coming into the world in a couple of years. Yeah. Thanks so much for having me, Virginia.
Thank you. This was amazing. Thank you so much. Thanks so much for listening to Burnt Toast. If you'd like to support the show, please subscribe for free in your podcast player and tell a friend about an episode. This is a great one to send to all of your other friends who are in their 40s, 50s, 60s and dealing with the change. And please leave us a rating or review. All of this really helps us grow and find new listeners. You can also consider a paid subscription to the Burnt Toast newsletter. It costs just $7 a month. You get a ton of free perks and you get behind all our paywalls. Click the link in your episode description for that. The Burnt Toast podcast is produced and hosted by me, Virginia Soul-Smith, and Corinne Fay. You can follow me on Instagram at @B_Soulsmith. You can follow Corinne at Selltrade Plus, an Instagram account where you can buy and sell plus-size clothing. And subscribe to Corinne's newsletter, Big Undies, at bigundies.substack.com. The Burnt Toast logo is by Deanna Lowe. Our theme music is by Faraday, and Tommy Heron is our audio engineer. Thanks for listening and supporting anti-diet, body liberation journalism.